This is a case of cataract surgery in the presence of a small myotic pupil. It's just a routine cataract case. This patient happens to have some astigmatism at axis 90 degrees, so I go ahead and operate on the steep corneal axis to reduce this patient's astigmatism while also correcting their cataract. So it's all done like most of my cases under topical anesthetic only. Patient sedated with oral Valium, 10 milligrams. They're awake, but they're comfortable. I have anesthetized the eye with topical anesthetic, and then I moisten the cornea with OcuCoat. I then firm up the globe with OcuCoat. I've already made my conjunctival peritomy, so I go ahead and enter the eye. And at this point, I can tell that the pupil is not maximally dilated, but it looks sufficiently dilated. So I go ahead and proceed, always hoping for the best, but planning for the worst. That pupil looks to be, about 6 millimeters in diameter right now. So I use a bent needle cystotome attached to my OcuCoat syringe. Like most cases, I'll use one syringe of OcuCoat per case. I usually start in the center and then move my cystotome out toward 3 o'clock. And as I'm working on the eye, I'm starting to recognize that my 6 millimeter pupil is now moving closer toward 5 millimeters. Any shallowing of the anterior chamber will produce corneal stria, which will prompt me to reinflate the anterior chamber by infusing more OcuCoat through my bent needle cystotome. I like the bent needle cystotome because I can just go into the eye one time rather than creating an opening and then putting in a pair of utrotta forceps, which would require me to puncture with one instrument and then usually tear with another. Also, if I get shallowing of the anterior chamber while creating my capsulorhexis, if I used a utrotta forceps, I'd have to come out of the eye, put in more OcuCoat or more viscoelastic of choice, and then restart. This allows me to do everything with one tool. This is cataract surgery in real time. It's unedited, start to finish. Usually our cataract surgery times are anywhere from 8 to 10 minutes, but the more challenging ones will always require a bit more time. So now we've got probably a 5 millimeter pupil that we finished our hydrodissection with. Then we introduce our AMO signature phaco piece. I make sure I move my sleeve toward the handle to expose just the right amount of the phaco tip. I usually use bevel up. I get rid of my air bubbles. Then I create a central groove. I'll use my second instrument, which is a blunt chopping instrument, to crack, manipulate, and chop the cataract. Sprinkle a little more topical anesthetic on the eye just to make sure that patient's comfortable, and then we go. I create just a nice central groove. I don't try and go too deep, but then once I'm about mid-thickness through the lens, I can usually just crack it in half in the technique that you see here. I'll rotate the lens. I'll try and crack one half. my pupil small, visualizing the full extent of each nucleus hemifragment or quadrant is a bit more challenging. Still, I'm able to rotate the nucleus and at least at this point chop it in three pieces, one half and two quarters approximately. And knowing that my pupil's small, I go ahead and try and take one of the quadrants that I've created by increasing my vacuum on the phaco, lollipopping one quadrant up into the anterior chamber, and then emulsifying it. We use the Ellipse FX phaco handpiece, which is very efficient at safely removing very dense cataracts such as this one. Then I've already taken out one quadrant, so I'm going to go for the second quadrant. I try and keep all my instruments in the center of the eye, in the visual axis. I try not to chase after any material, lens material that is out in the periphery. I just try and bring all the lens material toward the middle of the eye where it's safe, so I reduce my chances of engaging the anterior capsular rim, the posterior capsule, and the iris. So here I've taken out now half the lens, and I have one half of the lens, which I'll spin around, and I'll try to just chop it. Again, I'll bring this half toward the middle by lollipopping it. I'll be careful to make sure that my second instrument does not engage the anterior capsule leaflet. I'll chop it into several pieces to make it easy on myself, and then just emulsify it. I'll use the second instrument and place it behind the nuclear fragments as I phaco, and that's just an extra safety measure to prevent the phaco tip from inadvertently nicking the posterior capsule while we're on higher vacuum mode. Again, this is my last fragment. My second instrument goes behind or posterior to the nucleus as I emulsify these last fragments. I've now gotten most of the nucleus, but we'll kind of spin these small remaining fragments around so they're easier to remove. There's usually some material that can get stuck near the paracentesis port, so we grab that piece as well. Now that I'm pretty much finished with the phaco aspect of the case, I'll stromal hydrate my paracentesis incision to blow out any remaining fragments that may have become hidden near the paracentesis port. And as I do IA, I know I'll have a hard time seeing the cortical remnants, so I'll use a collar button to essentially widen the pupil as I finish my irrigation and aspiration. This is just a simple way to gain exposure of the equatorial cortex in the presence of a small pupil without using iris retractors or other pupil expansion devices such as the Malyugin ring. So I don't want to ever place my irrigation and aspiration tip where I can't see it, so I just use the collar button to reveal the area aspiration tip. The INA tip is made of has a silicone sleeve on it, which is very capsule friendly. This silicone sleeve is made by MST Microsurgical. So because we use the collar button to expand the pupil, we've been able to remove most of the cortex. We use the silicone sleeve to also polish the posterior capsule to kind of clean away any sticky cortical fragments that want to stick to the posterior capsule. I like to polish the capsule to reduce my rate of posterior capsule opacification, which might necessitate a YAG capsulotomy later on down the line. So now we've safely removed the cataract. Our pupil now looks to be about 4 millimeters in diameter. We fill the eye with more viscoelastic. I use a Bausch & Lomb Li61 AO lens, and I insert it into the capsular bag. This is an excellent insertion system because it allows ease of insertion of the IOL into the capsular bag, all with the insertion system. So we get the leading haptic, the optic, and now the trailing haptic all in the bag in essentially one motion, which is really nice. So then we go ahead and firm up the globe, hydrating the paracentesis port. We remove the remaining viscoelastic, and we have another happy customer who's had a nice, safe cataract surgical procedure. Most of my cases, I'll spin the lens in the bag to bring out any residual cortical fragments. I'll usually also place my irrigation and aspiration tip behind the lens at some point to aspirate the viscoelastic from behind the lens. Here my tip is behind the lens, and I'm just aspirating out the visco that may be trapped behind the lens. We just stromal hydrate our incisions. The 2.8 millimeter incision that I made at 90 degrees usually will cause about 1 diopter flattening along that corneal meridian. That looks great. Thank you for your time and attention.